So I am delighted to be back here with you. Atul and I think each year are inspired by the fact that a whole state would come together and bring the kind of excitement and the passion and the commitment to decreasing variation across the state of South Carolina. I want to welcome you all here. I also want to welcome all of those of you who are on webcast. I know that the organizers of this meeting are really interested in getting everything to be shared across the state and even beyond. And so I'll welcome all of those of you who are joining us by webcast. I do want to also congratulate you on the big shift I'm seeing here in South Carolina from working mostly within hospitals to looking at even the name of the conference now, to think about transforming health. It's an amazing step forward to say not only will we create reliability within our organizations, and we can't move away from that, but that we're also going to move to expand and to begin to think about health in a different way. It's a really exciting time, especially for me at IHI, because what I'm seeing across the country is that in many ways we're a little bit weighed down by the gravity of all of the change that we're going through. People are telling us that they can see that we've got to change. They see the future, but they feel weighed down by the gravity of payment systems, of changing demographics, of the increasing burden of disease. And so at IHI, we're developing a new way to think about this, and we're calling it escape velocity. It's the velocity that we need to escape the gravitational pull that we're in. And that's why I was so excited to see you all here today, because I feel like we're in that beginnings of escape velocity. So let's start by celebrating your progress. What an amazing couple of years you've had. I mean, we've seen improvements in patient safety, in maternal and neonatal care, in the surgical checklist. Looking across the system, what you've done is create a learning community. I don't think it's fully mature yet, but it's a wonderful start to say we have an obligation, kind of an ethical obligation, to all teach and all learn within the state. That our citizens really depend on us as healthcare professionals to create a learning system so that we can close any gaps in any variation. Healthy Columbia, the move from a focus on organizations to a focus on the community, a move from improving to transforming. It's all, I think, an exciting time for us to begin to move toward the IHI triple aim. So as we look ahead, we're looking at the IHI's triple aim as being not only in your lower left corner, how do we improve the experience of care, safety, access, effectiveness, efficiency, and the like, patient-centeredness, but how do we do it at a lower cost per capita, and how do we begin to integrate the notion of population health? It's still foreign to many of us. When we invented the idea of the IHI triple aim back in 2007, we actually took this platform and we brought it around the country, we brought it around the world, and we asked people, do you see yourself here? And some people said, well, I'm a healthcare provider, I'm a physician, or I'm a hospital executive. My job is to worry about the experience of care. We had economists and CFOs who said they were concerned on cost per capita. And we had public health people and people who were out in the community working on population health. But we didn't really have anybody, even the integrated systems that you would expect, jump in and say, I'll take it all on. So we put that little dot in the middle, and we said what we really need to do as healthcare leaders around the world is step into that dot, the role of integrator, and take on a different way to see our job, because the work is so different now. So I'm asking you to step into that black dot today with me, escape gravitational pull, and work toward the IHI triple aim. It's really an exciting, I think, and wonderful time. When I was here a few years ago, I talked a bit about the determinants of health. And I think what you'll see as we go through these days is you'll hear people talking about all of the different elements of the triple aim: measurement, finance, how do we think about new models of care, how do we think about segments. But I come back to this important slide, which is the WHO definition. It says that that health is the condition, the determinants of health are the conditions in which people are born, grow, live, work, and age. And then they put ... including the health system. So we're not one of the big drivers of health. I'll often show this diagram to demonstrate the determinants of health. And then healthcare executives, I see, will often lean in to say, where are we? So I put a little circle there. So you can find our contributions to health. This is the old way to think about health. This is the old way to think that your 15-minute visit twice a year was our contribution to your health. What we're moving to now is a totally new way to think. You can look at this slide and say, there's no way we're going to create healthy Columbia or healthy South Carolina if we only work in that little circled area. We've got to co-produce health. We've got to come together with all of the assets in the community and start to think in a very different way about what it means to step into that black dot of integration. Now, I'm going to share some bad statistics from my home state. I could have done South Carolina, but I thought I'd be humble and bring my own bad data. But it's like this across the U.S. And I think it demonstrates in a different way how we've got the system focused in the wrong direction and how serious the gravitational pull is. Recently, the Boston Foundation partnered with a not-for-profit up in Massachusetts and produced a health report for our state. And when you look at it, you look at the dramatic mismatch between what we're spending money on and the determinants of health. If you look here as an example, that access to health care is the top green bar. That's what contributes to health, but you can see how much money we're spending on the healthcare system. You can just look at this and see that those determinants in the rainbow are not where we're spending our money, and I think that's why we're stuck with gravitational pull, not being able to make the kind of progress we want to make on health. Here's the spending imbalance. You can see the first big blue bar is how much increase we're seeing in healthcare spending in the state, and how that's taking away from education, from safe communities, and that pull is spending more and more on healthcare encounters and less on the real determinants of health. You can see, if you look at this at-a-glance report card, and you'll have all these slides so you can reference them when you return, that we don't do well on the determinants of health. We're not focused on decreasing access to high-sugar drinks. We're not focused on creating healthy environments. And yet the data that I showed you demonstrates that that's perhaps where the co-production of health will have the greatest impact. So I think what we're doing at IHI is beginning to think about how do we move away from the gravitational pull, and how do we shift over to thinking about the triple aim in a different way. We need to transform health, and I think it's the same challenge that you're seeing here in South Carolina. So I'm suggesting that we need to flip healthcare. We need to think about healthcare in an entirely different way. At IHI, we're flipping from a deficits-based approach to an assets-based approach. And we're beginning to bring communities across the country, across the world, together. And when we first sit with the leaders in a community, whether they be school teachers or public health leaders or hospital executives, the conversation inevitably begins by measuring and talking about the deficits. It's like where we're going because of this gravitational pull. And so people start talking about increasing obesity rates, and then what happens with rates of diabetes, about kids dropping out of school, and about drug problems, rampant in Massachusetts right now. So we're looking at the deficits base, and yet we don't look at the assets map. So what we're suggesting at IHI is if you come together and walk into that black dot of integration, we're going to need to move from a focus on the problems only to a focus on what assets we have in the community. When we go into a community at first, we'll sit and have a conversation and inevitably can produce in a day or an hour the deficits map. And what we need to do then is move to the assets map and look at all of the people in the community, the organizations in the community, each one working in a disconnected way, in a disorganized system, each one trying as hard as they can to make a dent in their own little way, and yet not coming together. So I think anybody who steps into that black hole is going to start to see all of the assets of a community, and it's going to give us the energy and the resources that we need in order to produce better health. It's the only way, I think, that we can get to the triple aim. So I stepped outside of healthcare and I said, where have we seen this kind of transformation? We're in need not of improvement, but innovation. We're in need of really looking at transformation. And I said, I think I need some lessons. So I spent the fall out studying other social sectors, both in the United States and abroad. And I guess the one that I wanted to share with you this morning is a wonderful lesson called Flipping the Classroom. Have you heard about flipping the classroom? So in the old days, a teacher would get up like I am this morning, and the students would come in and they would give the lecture. And these teachers, if you talk to them, give the same lecture all the time. They give the lecture and then they give the students homework, and the students go home and they do their homework alone, often, in isolation, and some of them struggling with hunger and domestic violence and all these issues that a kid is trying to figure out at home. Well, flipping the classroom came from a coach who was a principal, and he realized that when he was teaching, he was standing up in front of the class. He was the sage on the stage. But when he was coaching, he was the guide on the side. And he said, maybe we need to flip the classroom, just like I coach my sports teams. And instead of me giving a lecture every day and then giving the students homework, I'm going to tape all my lectures, and I'll have the students watch them either at home the night before or in the AV part of the school, so that the students watch the lectures by themselves, and when they come into the classrooms, they're working together. The results were dramatic and are transforming education. The students' results are flipped in every single grade. In every class, the failure rates dropped. Graduation rates are rising. College attendance is increasing. And most importantly, I think, the flipped classroom closed the gap between those most in need and the students who were at the higher end of the class already. Because what happened is the silent failures, the kids who were struggling, it became apparent when their teachers were working with them in the small work groups in the classroom, and they could then reach out and close those gaps on private failing. I think the issues here have a lot of lessons for us, because it is the one intervention that I could find outside of healthcare that closed the disparity gaps and simultaneously raised the graduation rates and the college attendance for the higher performers. So I think it's a unique way for us to think about healthcare. As I started to think about it, I thought about some patients I'll introduce you to tomorrow. But I started to think about this notion that our medical interventions are so small and so separated that us expecting us to have an impact on health, to be able to co-produce health, when you see your doctor once a year or maybe twice a year, it's really ludicrous, and we need to flip healthcare, just like they flipped the classroom, and co-produce health. So at IHI, we're thinking it's evolving mental models. We're going from, in the 80s, where patient satisfaction was about improving facilities or improving technology. And then in the 90s, we talked about customer service. And in the 2000s, we said we're going to improve the patient service experience. And now we're engaging in co-production. The role of the physicians in the 80s was they were the customers. I was a hospital CEO in the 1980s, and the physicians were my customers. I didn't think about the patients as my customers. I thought about the physicians. How do I make them happy individually and as a group so that they'll keep on bringing patients to my hospital? And then in the 90s, we went to physician cooperation and then engagement, and now we're seeing physicians leading this charge of transforming the healthcare system. In cost reduction, we're seeing similar evolution. In the old days, it was just managing the inputs to the process, managing the resources. And then it was managing length of stay and access. And then it was removing waste. And now we're looking at totally redesigning care. You're going to see so many examples here these 2 days of flipped healthcare designs that will give you all of the triple aim, because we're looking at new care models in a very different way. And performance measurement has transformed from JCH accreditation to really thinking now about how do we decrease variation and use data for payment in a very different way. So last night, some of the faculty got together at a restaurant here in Columbia. And on the way back from the restaurant to the hotel, I was walking down the street and I met an amazing woman. And so I stopped to talk to her, and I ended up talking to her for about 35 minutes, I think, on the sidewalk. Her name is Janie, and she was in a wheelchair with a rescue dog, and she was having a cigarette outside a bar. She's a fantastic woman. And as I started to talk to Janie, I was asking her about her health, and she was describing to me that she was born with cerebral palsy and the challenges that she's had throughout her life. And we had a wonderful conversation. And I was sitting there thinking about, how do we look at Janie? How do we look at her? And if she were to come into a clinic or come into a hospital, I think what we would do is we would start to think about Janie in terms of her clinical challenges. I was asking her, who dresses you in the morning? And she said she's got a nursing assistant who comes in and helps her get dressed. But Zuma, the dog, gets her undressed at night. And so Zuma is totally trained to get her undressed and to help get her to bed. And so I kept asking her questions about her life, her independence, and I kept going back in my head to thinking that we would medicalize Janie. We would think about Janie's needs. We would start to think about how expensive it is to replace tires on her wheelchair, or how many visits she would need in a year. And yet, as I started to talk more with her, I began to see the assets in Janie. I said, Janie, what do you do for a job? So she's got her master's degree. She's got 2 degrees. One is from the University of Wisconsin at Madison, and the other is from another college, and I forget which one was which now. But I said to her, what do you do for your job? And she said, I'm a vocational counselor for people with disabilities. And she said, I give them hope. She said, my parents, when I was born, said, okay, you've got cerebral palsy, get over it, and then get on with your life. And so she works, she travels around the world, she's been engaged twice. She's a fantastic and wonderful woman who is an asset to the healthcare community. And I just asked her, I said, Janie, can I take your picture here? Because I wanted to show you that in some ways we've medicalized ourselves. And if we're ever going to get to the triple aim, we've got to flip healthcare and start thinking about Janie as an asset for us all. She said, I love to teach patients. She said, even more, I love to teach doctors and nurses that we are different. We're not just medical people. We can help you. I can co-produce my own care with Zuma, and I'm teaching others how to get over their disabilities and how to create health in their own lives. And so I invite you today, tomorrow, to not see the deficits, but to move to asset-based thinking, to really start to look at everyone here in the room like Janie and say, how can you help? What can I do to partner with you to produce the triple aim? Because the old medical model needs to go away. That's the gravity holding us back. And we need the escape velocity to really move to a totally different way of thinking. So I would say there are lots of Janies out there. I just happened to spend the best half hour of my day with her last night, walking down the street and stopping to ask her questions about the challenges she faced. It was an incredible thing to meet her, even more incredible to meet Zuma, and to Zuma would give me high fives anytime I'd say, Zuma, give me a high five. She puts up her paw. And it was wonderful to watch Janie, because Janie had little verbal cues, and she would either make a noise or she would signal to Zuma that she needed help. And Zuma was off talking to other people or patrolling the sidewalk, and all of a sudden Janie would make a little noise and Zuma would come right up and jump up into her lap. And I thought, if clinicians could only be so attentive to the subtle signals our patients send, it would be really powerful. But I think we're so into the medical model that we're so busy giving our speeches or writing prescriptions or telling people what we want them to do that the subtle signals get lost. And yet Zuma was demonstrating yesterday so effectively how amazing she is at picking up on those signals. So I am excited to be here with you all because today's the day we're going to start flipping healthcare. We're going to escape velocity. And to help us to do that, I have the great pleasure to introduce my friend Atul Gawande, who's going to help us to think in a very different way about these systems of care. Atul, I think we all know him. He is a surgeon. He is a writer. He's a researcher. He has so many titles that I won't go through them all. But to me, what Atul's greatest gift has been is to close the gap between the healthcare professions and the lay public through his work in writing in the New Yorker. I know Atul writes for the public, and he's brought so much of the kind of complexities of the healthcare system and the co-production challenges that we've got to the fore through that writing. But I have to say, I often work with healthcare leaders around the world, and they race to the New Yorker to find out what to say once Atul is published, because he, in fact, is the person that brings us all together. So help me to welcome Atul Gawande.